Moving on to bias mechanisms. So in our studies, we typically have two concerns. There's the random variation or lack of statistical precision, and then there are the systematic errors, that is bias. While we have bias as an overarching term, we can typically refer these mechanisms into three different baskets, be it selection bias, information bias, or confounding. Our statistical colleagues know how to handle and describe random variation, and once identified knows models to address the confounding issue, whereas we as epidemiologists know stuff about selection, information, and confounding as sort of the more general ways a study can be designed incorrectly, the biases that might affect a study. This is the classical representation of these two different aspects. The first circle here is with low precision, however systematically correct on average. The second one is systematically incorrect and with low precision. The third is with high precision, however still systematically incorrect. And the fourth one denotes what we would like to do, high precision and with no systematic error. So what we want to focus on here are the two middle ones, that is, regardless of precision, whether there are mechanisms that makes us systematically miss our target. So we have different types of biases, and I will simply go over the more important ones here. We have selection bias, that is bias on what gets into our study. We have information bias, sometimes referred to as misclassification bias, that is misclassification of info in our study. Protopathic bias, which is the classical term, but sometimes, fortunately, is referred more sort of elegantly to as reverse causation bias, immortal time bias, and then confounding. And confounding I'll save for a presentation in its own right, so I'll cover these four types of biases. Selection bias. Selection bias is a bias coming from outside of the material due to selective inclusion of individuals with particular characteristics, and this is dependent on, for instance, their exposure or their outcome. An example could be women with vague symptoms of DVT have a higher likelihood of getting admitted to tests if they're using oral contraceptives. Because oral contraceptive is a risk factor for DVTs, this might be part of the medical workup, and thus it might change the threshold for getting workup done. This means that if you are looking at individuals with a DVT diagnosis, you will likely have a selection bias from people with a higher use of oral contraceptives than the average population. Not only because it's causing a DVT, but also because there is a likelihood of the exposure in itself making it more likely to get into the study. And in a direct analysis, this might overestimate or inflate the association between oral contraceptives. It is causing the outcome, but it also, as an indirect sort of way, is a reason for getting the workup done. Another example of selection bias would be mothers of children with malformations that are invited to participate in a study. If they had thought about a given drug they would might have considered leading to the malformation that their child is afflicted by, this makes them more likely to participate in the study because they have something to report. And thus we see increased use of drugs among those agreeing to participate in such a self-reported study. Information bias. That is bias from within the material due to incorrect information. That is not a matter of who gets into the study, but the data we have on the individuals in the study will have varying levels of quality. And we divide this typically into differentiated and non-differentiated information bias. Whether this lack of validity does not depend on the exposure status. So if it is differentiated, that is, it depends on whether the patient has an outcome or the exposure ascertainment, or whether the outcome ascertainment depends on whether the participant is exposed or not. This could, again, if we use the mothers of children with malformations example, if we have everyone in the study, but we ask them whether they used a drug during their pregnancy, those that have an outcome will have thought about the pregnancy in a different light and have a higher likelihood of having something to report and remembering what they have been using, whereas with those without an outcome, that is no malformation, will much more likely have forgotten what they did in terms of drug use during the pregnancy. As a result, we end up seeing that drug use is associated to having malformations, irrespective of this being causal, but caused by this differentiated recall of information. We could also see non-differentiated information bias, that is general misclassification or exposure or outcome status or other variables, and sort of no interplay between the two. This will always infer bias towards the null, seeing no difference between the groups compared, because this is a matter of sort of diluting the effect of the differences. An example, we did a study on the risk of brain hemorrhages associated with use of platelet inhibitors. We have the classification of non-use and use, as discussed in other presentations, highly dependent on assumptions made. It is not 100% correct, and thus we might have some classified as stopping that are in fact still users. We might also have someone that did in fact stop but classified as users. So there's a slight misclassification there, which will be independent on outcome, just a matter of a bias towards the null. And a more dramatic example, also from the same study, we had performed analysis without realizing 1 year's worth of prescription data was corrupt. So in the middle of the study, there was a year of data missing for everyone, and thus a major misclassification of users into non-users, which led to a fairly strong bias towards the null. Then we have protopathic bias. This is the classical term. I see increasingly the term reverse causation bias instead being used, which is a much more useful metric, useful nomenclature. This is a mixture of reversal of the cause and effect pattern, that is a drug given for an early, not yet recognized, or at least not yet recorded disease. For instance, we could take a look at the association between valproic acid, it's an anti-epileptic, and risk of cancer. There is an increased risk of brain cancer, but this is caused by valproic acid being prescribed due to epilepsy that is caused by the brain cancer not yet diagnosed, but leading to these symptoms. In the previous presentation, I used this example that across very many different cancer outcomes, we see this increased use of drugs leading up to, which infers a risk of protopathic bias. This was the case control approach. In a cohort approach, you could see something like this. This is the use of drugs against overactive bladder, and you see a markedly increased rate of bladder cancers happening within the first 6 months of the exposure, which is unlikely to be caused by the exposure. Nothing causes cancer within such a short time frame, but it's a mark of the drug being given for something that then turned out to be a cancer. Reverse causation bias is most definitely also a thing outside of cancer. This is just the more dramatic examples. Then finally we have immortal time bias, also referred to, at least by me, as the epidemiologist messed up bias. And this is better illustrated with an example. So here's a study on looking at the survival of Academy Award winning actors and actresses, and here they conclude that those winning an Oscar, they tend to live longer than colleagues not winning an Oscar, and thus they incorrectly conclude that winning an Oscar and having a high social status and living a fortunate life such as this is in itself a predictor of survival. However, this is a result affected by immortal time bias, illustrated here by this seminal movie, Rebel Without a Cause, starring 3 talented actors. All 3 of them were very talented, all 3 died at a young age, all 3 were nominated for receiving an Oscar, but neither of them ever got one. This is an Oscar winner, Christopher Plummer. He won his first Oscar in 2012, nominated for the first time in 2010. And what is the concern if I compare his life trajectory to the life trajectories of the 3 actors I highlighted just before? And basically, this is the type of bias inferred. If I did such a comparison, I would in fact compare time already survived, which is by definition immortal, to time that hasn't yet been survived, as in the case of the young actors. And the fact that they didn't get to a high age is the type of selection bias that sort of didn't get them into my study as Academy Award winners. So in this particular setting, you should have compared aspiring actors and followed them over time, either prospectively or, and in your analysis, go back and then follow them over time, instead of having this comparison of those already having survived and achieving a high age to those that didn't. This is unfortunately a reasonably common thing in pharmacoepidemiology, immortal time bias. And for historical reasons, this has been illustrated quite often with studies on inhaled medication against asthma. In this particular study, also afflicted by immortal time bias, we have followed 22,000 patients for a year after being discharged after a COPD exacerbation. They are divided into users and non-users based on whether they filled a prescription within 90 days after discharge. And this reports some dramatic effects, with both readmissions and mortality being reduced by a lot. If you look at the survival curves, you can see that there is sort of a dent in the survival curves, in that something is happening up to the first 3 months corresponding to the inclusion window, and then a different trajectory from there on. The mechanism here of immortal time bias comes from the fact that you are following people from the discharge state. However, you are grouping them into users and non-users in terms of what is happening within the first 3 months. This means that the likelihood of getting into the exposed group depends on you not dying and surviving long enough to getting the prescription and have being classified. But if you are classified as a prescription user, inhaled medication user, after 2.5 months, you have all your person time classified as exposed, also the 2.5 months leading up to this prescription, which is, of course, effectively immortal, because had you died, you would not have gotten that prescription that had your person time or observation time classified as such. So this combination of ascertainment window and follow-up period with this incorrect retrospective classification of use and non-use based on what happens in the future will lead to some fairly spurious results. This type of bias is typically ascribed to Sami Swisser, having described this among other places in the seminal paper on immortal time biases. It has also been described previously here by Su et al., describing a similar mechanism. So just to summarize, what is incorrect is, in this inhaled corticosteroids example, having someone followed from discharge until for instance, mortality or other outcomes based on whether a prescription happens during follow-up. What should have been done is to classify the individual as unexposed up until the prescription and then exposed from there on. At any time, if you are using a crystal ball, that is, if you are at any time evaluating exposure or follow-up or outcomes based on information that isn't available to you at that time, such as here classifying someone as exposed based on information that isn't available but only later on, that a prescription happened later on, you are in a situation where you might infer time-related biases such as immortal time bias. Immortal time bias always happening in cohort studies. It's very difficult, all bordering impossible to do in a case-controlled study. If something is too good or strong, that is to be true, if the effect manifests quite soon, because it's typically a matter of this sort of selection mechanism, there is a use of a crystal ball, classification of exposure or other metrics depends on stuff that happens later on. And a typical marker is if someone analyzes groups, users versus non-users, instead of status, that is exposed time versus unexposed time, then there is a increased likelihood that someone has made this division based on future information. So immortal time bias, some of these are difficult to avoid. This one isn't if you conduct your study in a correct manner.